Hello, I am Dr. Mirela Cerneianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Hello, listener. Today's episode is continuing a series on fertility. And in this specific episode, I would like to talk about fertility factors. And actually, this is the beginning of a conversation that's going to extend probably for about 3 episodes or so. And these fertility factors are pretty much the major obstacles on a couple's journey to achieving a live birth, to starting a family. So in this episode, I will limit myself to the first 2 factors, and I will discuss the rest in the future episodes. So what you should know about these fertility factors, let me start by talking about when you're planning on starting and growing the family and having another child or your first child, and it has been challenging, what do you do? Let me first start this episode by discussing what would be involved in a basic fertility workup. Also, I'd like to talk a little bit about how do you know you might have a problem and when to seek help. So let me discuss how you should plan this as a couple, obviously assuming this is a couple's journey, which it is in 99.9% of the cases. So the standard of care current recommendations are that if a healthy young couple in their 20s and 30s cannot conceive spontaneously after 1 year, and the couple is not using any birth control, they should seek help. Now, personally, I believe, based on what we're now calling the infertility epidemic, that we should strongly reconsider this 1-year interval, especially for women in their 30s. I personally recommend that if more than 6 months have passed, and as a couple, you have been actively trying without any success to have a child, then you should make an appointment to see a doctor and be very honest about the purpose of the appointment. Why do I say that? Because your medical insurance company will not cover fertility consultations. So be prepared to pay cash out of pocket for the consult. And this should be a couple's consult. So come in as a couple, and usually the cost of the consultation covers both partners because it's a fertility consultation involving the couple. After the initial consult and the completion of workup, labs, or tests, likely there will be now 2 separate patients because there will be issues with one partner or medical problems that need to be addressed with that side of the relationship. And sometimes both the female and the male partner have health issues that need to be considered. So obviously, going forward after your initial consultation, there will be different consultations focused on different topics of care and further testing to continue the workup and the treatment for that specific couple. So again, consider the 6 months interval and seek care to at least get some basic workup. And I'll talk more about the workup as I discuss each factor and present it to you. So let's talk about the number 1 fertility factor that we need to consider and one of the major obstacles in a couple's chance of success to achieving natural conception and a live birth. Well, it is the male factor. The male factor is a critical factor in this equation of fertility. It's also very easy because as a couple, you should always consider male factor first, simply because this is such an easy and short workup. All the doctor needs is a simple sperm analysis. If you have good sperm, good motility, good morphology. So the sperm is moving well. It's genetically looking normal and has a normal shape. And you have a good number, that eliminates the male factor. So we don't need to worry about the male anymore. Please keep in mind that the male factor is an issue estimated to be the problem in 30 to 50% of cases of couples infertility. And the male factor is the main problem in about 20% of all infertility cases. So I don't mean this to scare you as the male partner, but it is important and is really easy, because as you're going to hear, once I get into all the other factors, there are a lot of factors that are involved in a woman's fertility as a possible issue or obstacle. But for the men, there's just one thing: how good is the sperm? So see a doctor as a couple, have the couple consultation, and decide when and how the male should be tested. And ideally, on top of the sperm test, it's always good to check some basic labs: the kidney, the liver, the thyroid, maybe the cholesterol, and definitely check for anemia and some vitamins. If there's any kind of problem with the sperm, then obviously the men will have to have a urology consult, a testicular ultrasound, hormonal testing, and all of these might be appropriate, and possibly more tests. For a woman, it's very complicated. Let me outline all the possible factors that could come into play. And I'm going to start from the origin of the egg outward towards the opening of a woman's vagina. Number one, the ovarian factor. This is where eggs are stored and formed. Number two is the hormone factor. This involves the delicate balance of our brain pituitary sex hormones, the hypothalamus pituitary ovarian axis, which culminates into ovulation. And obviously, it's needed to sustain the pregnancy in the early stages. Number three, the tubal factor. The tubes are those thin conducts that collect, sustain, and propel the egg towards the sperm. It also serves as the meeting ground for the egg and the sperm, where the fertilization occurs. Number four, the uterine factor. This is the organ that will receive and accommodate and house the embryo, then the developing fetus, and finally deliver the baby during birth. Number five, the cervical factor. The cervix is the gatekeeper to the uterus, is a facilitator or possible barrier for the sperm, who definitely need to pass this organ to gain entry into the uterus. The vaginal factor is number six, where the sperm is deposited until it can make its way to the cervix. We need a functioning vaginal canal to be able to have sex, to have a child naturally. And number seven, last but not least, the unexplained factor. So in this episode, what I'd like to do is discuss the ovarian factor. So I will discuss the ovarian factor, the hormone factor, and in the next couple of episodes, I'll talk about the rest of the factors. But let's start with the origin, which is the place where it all begins, our ovaries. I'm going to call this the ovarian factor. This is the main cause of infertility for women and is responsible for about 40% of all causes of fertility challenges in a woman. Now, the ovary itself is not at all complicated to evaluate. And this is where the detailed medical history, the exam, some basic lab work come into play. This is where we need to know about your periods, how they come, how long they last. We might need to do an ultrasound on day 3 of your cycle to look at your ovaries and evaluate and count how many follicles we see in each ovary. That's your egg count. Again, expect to pay out of pocket for this ultrasound. Many doctors do it in their offices, and they can discuss the findings right then and there. They can point out on the screen, here's the ovary on the right, pan out from the left to the right, top to bottom, and we count the eggs, and you know exactly what's going on. And the doctor can also tell you, well, this is a low count. If we see 3 on each ovary, and this is a great count at 10 to 15, or you have a very high count, which suggests PCOS, if we have 20 or more on each ovary. So this is a much better solution on looking at your ovarian egg count, as opposed to a doctor ordering an ultrasound to be performed in an imaging center. Those ultrasounds, keep in mind, are done by a technician. Those technicians have minimal training. They are not allowed to talk about the findings, explain anything, show you anything. They will simply record images, which are sent to a radiologist who probably reads them from home and interprets them. And then the radiologist will send a written report to the doctor. So this could take an average of 2 to 7 days. And the technician likely will not be trained or know how to count follicles. And you will need to sweep the ovary again, transverse or sagittal view, sweep left to right, and count on each view. So it's a technique that they're not taught how to do, and it needs to be done live. I guess you can take images and images and images, and then the radiologist can count and give you the count, but it's just not being done. Usually that's something that's done in a doctor's office or an infertility specialist's office. So this is one way to look at the ovaries. We do lab testing, we do an ultrasound. But coming back to the lab testing, a very simple ovarian test, and I mentioned this in my previous episodes, is the ovarian reserve test. This is called AMH, or anti-Mullerian hormone test. This hormone is made by the cells that surround our follicles, which is also known as the egg, our eggs. And this hormone can be tested any day of the cycle. It's a very simple blood test, costs about $150 to $200. And what you need to know about this is that this test is always correlated with a woman's age. So let me give you an example. An AMH level of 1.5 in a 20-year-old woman, 2025, can be ominous, can indicate low ovarian reserve. But a 1.5 level in a 40-year-old woman could indicate a great chance of fertility and a very good ovarian reserve. So this number needs to be taken into context of age. So the ovarian reserve is a big issue, and the absolute number of the eggs is always important. I talked about this in my last episode. But I also explained that the egg quality is a big issue. And this becomes a really big issue as a woman passes into her mid-30s. And honestly, there is no great way or a simple test to check egg quality. We have some indirect information based on, let's say, if the levels of the estrogen and progesterone during day 21 of your cycle are low, that could be an indirect indicator of how much estrogen that egg could produce. Also, if we test vitamin levels in the blood, B12, ferritin, vitamin D, magnesium, if you have a widespread nutrient deficiency, this clearly could possibly affect the quality of the eggs. So indirectly, that might give us some ideas that you might have issues with egg quality. Keep in mind that our egg quality goes down as we age. It is not great after 40. I personally wish someone would have told me that when I was in my 30s. Why? Because we women can freeze our eggs. Yes, we can take advantage of modern medicine technology. We can recruit, we can collect, freeze, and bank our eggs when we're young. Now, here's the thing. Interestingly, most women who freeze their eggs are between the age of 35 to 40. But the best time to freeze our eggs is literally in our mid-20s, before we turn 40. And unfortunately, that is when we are at the peak of our fertility. Early 30s is probably not too late, but many young women no longer want to get pregnant when they're very young. So nobody's thinking about egg freezing, and everybody's taking for granted that when they're going to be ready to have a baby, the baby is going to come. Most women who delay childbearing probably do so to pursue education, careers, personal aspirations. I know I did that. For many couples, the decision to have a child is delayed, is postponed due to concerns about finances, concerns over childcare, which is a huge issue, especially with two working parents and no support from other family members. However, keep in mind, children do not need money. Well, they do need money for clothes and food, but not as much as you think. And they don't care about whether or not you have a degree. What they need is love, time, and good values. We live in a very rich country with many people who unfortunately live in serious poverty. I have seen women come to the community clinic for their pregnancy checks, accompanied by 2, 3, 4 little ones, as they had no one to leave them behind with. So they were the major caregiver. So they came to the doctor appointment pregnant with all their kids in tow. Now, the mother, the children, they all had worn out clothes and shoes, but they did not look starved, and they were pretty happy and content. Again, children need love. They need parents who care for them, who will nourish and protect them physically, emotionally, surround them with love and good values. Our children do not care for our degrees, our careers, our personal accomplishments, and they certainly do not care for our bank accounts. So this is maybe just a little bit of a side note, but if you retain anything from this podcast, it should be this. As we women get older, our fertility is weaker and weaker, like a light that is slowly extinguished. So think very hard about your goals and aspirations as a woman and how important a child would be for you. Because a degree, a solid bank account, or a multitude of life experiences of travel all over the world might not make up for the disappointment of not being able to have children. Many marriages can actually break based on this issue. If you know where you want to get, and if your journey means no children until after 35, please consider a conversation with your doctor. Consider testing your AMH levels as soon as possible, and depending on the levels, consider freezing your eggs as soon as you know that you do not plan any children until after 35 or more. Be aware that we live in the midst of an infertility epidemic. 1 in 6 couples has difficulty conceiving worldwide, and by some reports, in developed rich countries, 1 in 4 couples are affected by infertility. I digress. I will come back to this topic about infertility epidemic when I discuss other factors. Let me stick to my main topic today, which is the ovarian factor, and now comes the hormone factor. So when I said the ovarian factor is responsible for 40% of fertility challenges in a woman, it included the hormonal factor because the hormones are made by our ovaries. Our ovaries make estrogen, progesterone, and testosterone. These are what we call our sex hormones. And all of these hormones are absolutely crucial for our fertility as women. This is where this delicate balance of estrogen, progesterone, and testosterone is very important. This is a very complex issue. So assuming there is a great ovarian reserve of eggs for the woman's age with a great egg quality, there has to be a perfect and adequate control from the brain through the pituitary to allow for ovulation to happen. So yes, you could have eggs, but if we have other issues in the body, those eggs are not going to serve the normal purpose that they're there for. I personally attended a few fertility retreats in my 5 years of attempting to get pregnant naturally, and I heard a quote that I would like to share with you today. And what this woman that I seek care with and I attended her retreats said is that ovulation is a law of nature, but implantation is an act of God. I will come back to this and explain in more detail. But what is crucial for you to know as a woman is that ovulation is pretty much built into our DNA. Our body is born with ovaries ready to go when we hit adolescence. And as we mature and bloom into mature women, we come into our own reproductive fertility potential. Our brain knows what to do and will release gonadotropin releasing hormone, GnRH, every month, which tells the pituitary to make FSH and LH, follicular stimulant hormone and luteinizing hormone. Those are the 2 hormones that control your ovaries. Any psychological or mental health issue that would impact this chain of control will affect ovulation. Extreme stress, states of grief, duress, emotional distress, depression, or severe anxiety will likely impact your gonadotrope-releasing hormone release, which will dampen, that means inhibit, or will not exert the pituitary control that's required, meaning you might not have a period, or your period is all over the place as far as predictability, or they could come monthly, but they're suddenly much lighter than they used to be. That just means less hormones and erratic hormones. I will talk more about your periods, as this is a very important sign and indicator of a problem. Let's talk a little bit more about this brain control. Any brain pathology or tumors could impact fertility. A woman can develop a pituitary mini tumor called prolactinoma. This is important because the area that makes prolactin in the pituitary can grow excessively and could impact ovulation extremely unfavorably. Young women could also develop benign tumors called craniopharyngioma. Those are pretty bad. They develop and grow right above the pituitary within the brain. But again, any tumor that develops in our brain is growing in a confined space, and unfortunately will impact surrounding brain centers. And with this type of tumors, the pituitary will greatly impact hormonal control and ovulation. So if there is any kind of suspicion that we have a central problem, that there's a brain or a pituitary problem, then a brain MRI with a pituitary-focused MRI could be ordered to evaluate this area. So ask your doctor if you need to have an MRI, if your periods are skipping, they're super light, or they don't come at all. And especially if your prolactin levels are elevated. Another big problem with the hormonal factor is PCOS. It is estimated that 15% of women could have PCOS. Now, this is a very interesting chapter. I will reserve its own podcast episode, but let me just review some of the basics here. In PCOS, and I get this question a lot, what is PCOS? Well, in PCOS, a woman's ovaries recruit and waste a lot of follicles. So they recruit these eggs every cycle, but instead of one of them being selected to grow, manifest as a mature egg, that doesn't happen. There's no ovulation. The small follicles that get recruited grow very little. They make estrogen only, and without ovulation, there will be no progesterone. So a PCOS woman is always estrogen dominant. Now, the interesting fact is that she will likely be estrogen dominant in some circumstances with low estrogen because there is no progesterone. The little follicle cysts do not grow that much, and they do not produce a lot of estrogen quite frequently. However, if you have a cycle where a lot of these little follicular cysts get recruited, a lot of these eggs get recruited, consider the fact that there's power in numbers. So if you add very little estrogen made up by each little cyst times 20 to 40, you could end up with a lot of estrogen. There could be different presentations of the PCOS with very low estrogen and skipping periods for many months, or no periods for 6 months or more. Or there are women who have monthly or 35 to 45 day cycles, maybe every 2 to 3 months. But when their period is coming, they're flooding. They have heavy and long periods. Women with PCOS have high LH, and their FSH-LH balance is off. This is very easy to test, and any doctor can order this test as long as it's ordered at the right time of the menstrual cycle, which can be very challenging if you don't know how long your menstrual cycle is going to be. 32, 35, 45. If it's a mystery, then maybe see a gynecologist that understands your hormones before you have your hormones tested. I talked about this in my earlier podcasts when I discussed estrogen and progesterone. So if you want to understand your hormones better, please revisit or listen to the previous episodes where I talked about estrogen, progesterone, FSH, LH, etc. Our luteinizing hormone, LH, promotes growth and development of the tissue in the ovary that makes testosterone. Whereas our FSH, our follicular stimulant hormone, promotes follicular growth and development and promotes estrogen. Now, high testosterone is great because it is such an awesome hormone. But high testosterone with low estrogen is not good at all. It means you're not ovulating and your balance is off and you likely have PCOS. Also, PCOS in many instances is associated with insulin resistance and weight issues, as well as some abnormally excessive hair on the face and the body, as well as acne. PCOS is a highly treatable condition. In a sense, it is easier to get pregnant with PCOS because we can change the hormonal balance with so many things. We have diet modifications, we have exercise, we have stress reduction, we have acupuncture, we have herbs and supplements or medications that trick the body and make it ovulate even when a woman has PCOS. Now, keep in mind, PCOS is a major leading cause of infertility, and it is chronic, but it can be managed very well. It can be helped, and it is very treatable. Weight loss up to 20% of a woman's body fat when she's overweight can drastically improve her chances of normal ovulation, as this weight loss will trigger a better functioning of the HPO axis. There are also medications to help improve chances of spontaneous ovulation, like Clomid. This is the primary medication recommended for PCOS patients, as it can indirectly cause an egg to mature and release monthly. Again, expect that management with Clomid to perhaps be considered cash because that's a fertility treatment, and it requires different monitoring and different blood testing. The second-line medication for PCOS patients is metformin. This is an insulin sensitizing drug. It can be used alone by itself or with Clomid, and there might be higher chances of success if they're both used together. A third medication that we have available for PCOS is letrozole or Femara. This causes the body to make more FSH, which is the pituitary hormone we need for ovulation. And we need this FSH to help develop and grow a follicle to the mature egg stage. Also, infertility doctors, not regular doctors, what I've told you so far can be used by a regular gynecology doctors. Now, infertility doctors can use GnRH agonists, which are medications that are very similar to our own gonadotropic-releasing hormones. They act like the gonadotropic-releasing hormones and work to stimulate ovulation. Now, this is usually very expensive. A woman needs to inject herself daily. A woman that's undergoing this kind of treatment needs a lot of monitoring with labs and ultrasound. And last resort for PCOS, there is also surgery, and that's not very often considered. It's actually called ovarian drilling. So this is done with a camera. The gynecology doctor would put the camera through a small incision in the belly button, would use a few additional small incisions on each side of the lower abdomen to find and grasp your ovaries with instruments, and then on the other side would use an electric needle to drill small holes superficially. This process will help lower the androgen levels and reverse this androgenic environment with a lot of testosterone, characteristic of PCOS, which inhibits and suppresses ovulation. Now, this does increase the risk of scarring, and ideally is best to avoid any damage to the ovaries because it could impair your ovarian reserve. So it's not something that's done very often, but it's there for you to kind of know about. Now, you might ask yourself, okay, well, this is a lot of information I just provided here. How do I start the journey? Well, you start this journey by paying attention to your periods. Start charting and recording. There's tons of apps that you can download online, but your periods are crucial. It can tell you and your doctor so much about your cycle. I talked about this in a couple of episodes, and I described what a normal period is. If your periods are not reliably within a very narrow span of days, like they should always come around 26 to 28 days, or they should always come 27 to 30 days, then you might have a problem. If your period comes sometimes every 26 days and sometimes later, 32 days, that means your cycles are not predictable. The variety and the unpredictability of your cycles could spell out trouble in the ovulation department. See a doctor, get a health and hormonal check, as well as an ultrasound. If your periods are sometimes light and sometimes normal and sometimes heavy, and the flow is not predictably the same every month, then you might, again, have a problem. Light flow means possibly low estrogen, possibly due to central control or possibly poor egg reservoir quality. Heavy flow means the opposite. Plenty to too much estrogen that is likely not balanced by progesterone. Unopposed estrogen will lead to unchecked, crazy growth of the lining inside the uterus, causing bad, heavy, and crampy periods. So obviously, not having a period at all is a very bad and clear indicator that you have a problem. So please do not delay and see a doctor, even if you don't want to get pregnant, but you have these cycle changes in your body. Your cycle gives you a lot of information, and any abnormality in a woman's cycle could be a sign of a different health problem that she has. The thyroid, the adrenal, like I said, tumors in the brain, all kinds of health issues will impact the woman's cycle. So please pay attention to your period because it's very telling and it's a very important sign. Obviously, this does not apply to women who are on the birth control pill because you no longer have a cycle. It's just a fake cycle induced by the pill. But I'll talk more about that in a future episode. I will end here and I'll come back next week to talk about the tubal factor and the uterine factor. So please stay tuned. Thank you so much for listening. If you are one of my faithful listeners and you are finding value and enjoying these episodes, please feel free to leave me a review on whatever platform you're listening to. Also, if you find the content in these topics useful, not just to you, but to someone else, a friend, a loved one, or simply an acquaintance that you know could benefit from the knowledge I share here, please feel free to forward my podcast to them. If you live in California and you'd like to work with our practice to help you achieve your wellness goals, please go to our website, www.herabeautyandwellness.com, and request an appointment. It will be our privilege to help you in any way, shape, and form we can. Any suggestions on a topic of beauty, wellness, or anti-aging are welcome. All you have to do is go to the website, leave a suggestion into the AI chat, and I promise you if you ask, I will listen and add your suggestion to my list of topics that I want to get to as soon as possible. Please join our Facebook group, The Wellness Optimizing Warrior MD. It's a small growing community that focuses on wellness, on what's new, what's safe, and what works in beauty, wellness, and anti-aging.